And step B, LABA and theophylline is used. And in step 5, oral steroids should be added. And all the steps includes step 1, that is beta-2 agonist. Step care management for less than 5 years children. Here are the 4 steps. There is no steps in oral corticosteroids. This is the scoring system for self-management. Total score is 7. These are the 5 questions. Do you have dyspnea every day? Do you have nocturnal attacks of dyspnea 2 times in a month? Have you suffered from dyspneic attacks severe enough to necessitate steroid tablets or injections or nebulization? Do you have persistent dyspnea for last 6 months or more? Are you taking steroid tablets? In patient's baseline, that is asymptomatic stage, PF is less than 60% of predicted value. With this scoring system, we can put the patient in these steps. These are the scores 0 to 7. In 0, less than 5 years, is step 1, 1, step 2, 2, step 3, and 3 to 6 is step 4. And more than 5 years, 0, 1, 2, 3, 4, and 5 to 7. From step 1 to step 5. These are the management of patients in hospital or ICU. Initially, we take the history, do physical examination and some investigations, and start treatment immediately with inhaled short-acting beta-2 agonist, oxygen, and systemic corticosteroid, and see the outcome of the initial treatment. If it is a mild case, patient becomes stable, and proper medication and recommendation, give him advice and discharge. And reassess the child and see the FEV1, PF, oxygen saturation and other tests, and label them in moderate episode on assessment or severe episode on assessment with PF and the symptoms. Then the treatments: inhaled beta-2 agonist, corticosteroid, and if improvement, what should do? Then the good response, incomplete response, and poor response within 1 hour. Do the assessment, response, physical examination, PF, distress, oxygen saturations, and put them on discharge with good response. Continue treatment with beta agonist, consider corticosteroid, patient education, take medicine correctly, review action plan, intense follow-up appropriate step care, and if not good response, admit to hospital, systemic corticosteroid, oxygen, consider IV aminophylline, and monitor PF and oxygen saturation and pulse. If it is to admitted in ICU, inhaled beta agonist, anticholinergic, inhaled corticosteroid, consider subcutaneous IM or IV beta-2 agonist, oxygen, consider IV aminophylline, and possible intubation and mechanical ventilation. Now the British asthma guidelines developed in 2009, few months back. What are the clinical features? They divide the patient according to the probability. What are the features that increase the probability? More than one of the following: who is cough, difficult breathing, chest tightness, particularly hours at night or early morning or on exposure to trigger, personal history of atopic disorder, family history of atopic disorder or asthma, history of improvement in symptom or lung function test in response to treatment. These are the features which lower the probability of asthma. Symptoms of cold only, no interval symptoms, isolated cough in absence of cough or difficult breathing, history of moist cough, prominent dizziness, lightheadedness, tingling, repeatedly normal physical examination of chest when symptomatic, normal PF or spirometry, no response to a trial of asthma therapy, clinical feature pointing to alternative diagnosis. So, the diagnosis of asthma in children is clinical one. It is based on recognizing a clinical pattern of episodic symptoms in the absence of an alternative explanation. The new diagnosis of asthma children, the high probability, low probability and intermediate probability is already included in our new guideline. High probability the diagnosis of asthma is likely, diagnosis of asthma other than likely if low probability, and if it is intermittent, diagnosis is uncertain. And how to manage? These are the high probability, intermediate probability and low probability. These are the algorithm. If response, continue treatment, no response, assess again. And low probability, if response, again continue, and if no response, further investigations should be considered. These are the step care management from their guidelines. Step 1, mild intermittent, then regular preventer therapy, initial add-on therapy, persistent poor control, and the use of daily steroid, continuous or frequent oral steroid. This is for 5 to 12 years old child, and this is the less than 5 years child. There is no steroid, oral steroid in step 5. And here is the acute asthma children management, when we should say that acute, severe and life-threatening. These are the points: oxygen saturation, PEF, and completion of sentence, breathlessness, pulse, respiratory rate, and criteria for admission. Beta 2 agonist should be given as the first line treatment. Increase beta 2 puffs 2 minutes up to 10 puffs. Refer to hospital if not improved with puffs on the way. Consider intensive inpatient treatment if oxygen saturation is less than 92% after initial bronchodilator. The following clinical signs should be recorded: pulse rate, respiratory rate, use of accessory muscle, amount of wheezing, degree of agitation. Note, the clinical sign correlate poorly with the severity of airway obstruction. Some children with acute asthma do not appear distressed. And these are the options: oxygen, beta 2 agonist, bronchodilators, steroid therapy and other therapies, how to use and when to use. And this is the management of acute asthma in less than 2 years. Most of the children of less than 2 years asthma diagnosis is very difficult. Intermittent wheezing is due to viral infection, bronchodilator response is inconsistent. Differentials of symptoms: aspiration pneumonitis, pneumonia, bronchiolitis, tracheomalacia, congenital anomalies and cystic fibrosis. Prematurity and low birth weight are risk factors for recurrent wheezing. Treatment of acute asthma with beta 2 agonist, bronchodilators and steroid therapy. And how to prevent? We know primary prevention with non-therapeutic intervention and secondary prevention with therapeutic intervention. Primary prevention of asthma, what we could do: exclusively breastfeed, low salt diet, more fish, outdoor sports and summer indoors, proper ventilation in home, reduce weight in obese and change job in occupational asthma. And don't, lactating mother should avoid allergic foods, avoid carpet, avoid broad spectrum antibiotics, avoid outdoor pollution, quit active smoking and passive smoking, avoid long time in front of TV or computer. Thank you all.
Request to my all colleagues: if you are to start high dose of corticosteroid, especially IV, please go on to insulin infusion. Second speaker, there is no difference between the treatment of pregnant asthmatic and non-pregnant asthmatic. We can expect that the output of treatment and outcome of the treatment of both breastfed pregnant breastfed mother should be same as well as for the children. I must thank the third speaker. My sincere thanks once again for him, because he mentioned he was very specific. Fourth speaker, I think he was giving a guideline to the treatment and management of the bronchial infection. With this, I thank again to the speaker, my co-chair Professor Sharfuddin, moderator, and the audience of this session. Thank you very much.
Both are